Welcome to the Lymphoma Research Foundation's Update on Oral Therapies and Adherence in Lymphoma and CLL webinar. I'm Andrea, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have the opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. If you are listening by phone, you will be asked to ask your question during our Q&A session. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time to join us on today's Update on Oral Therapies and Adherence in Lymphoma and CLL webinar. We'd like to thank our sponsors of this webinar, Genentech and Pharmacyclics and Janssen. We have callers from 37 states across the U.S., as well as patients and caregivers from 6 countries around the world. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Michael Williams. Dr. Williams is a professor of medicine and division chief of hematology and oncology at University of Virginia School of Medicine. Dr. Williams' research interests are in novel therapeutic approaches for non-Hodgkin lymphomas, mantle cell lymphoma, and CLL, including targeted agents and immunotherapeutics. He serves on the scientific advisory boards of the Lymphoma Research Foundation and the European Mantle Cell Lymphoma Network, and is vice chair of the Eastern Cooperative Group Lymphoma Core Committee. Dr. Williams, I will now turn the talk over to you.
Well, thanks very much, Jessie and Andrea, and let me also welcome everyone who's taken the time to join us today for this Lymphoma Research Foundation webinar. So, as my experience with LRF presentations is that we have a very sophisticated audience and very informed individuals who join in on these calls. And so what I wanted to do is focus on a few specific areas that have been an interest for the Lymphoma Research Foundation. I'll give you the background on that in a moment. But before we start on the slides themselves, I want to preface this by just mentioning the fact that it's really a dynamic, dramatically important time in the treatment of all types of lymphoma and chronic lymphocytic leukemia. We are rapidly moving away from our traditional reliance on standard chemotherapies. By that I mean cytotoxic chemotherapy, where you might get an infusion every 3 or 4 weeks. It often comes with short and sometimes longer-term side effects, and these are still very important in what we do, and in fact can cure or control disease for years and years in many patients. But we're now moving into an era where we've got a good understanding of the drivers, the pathways that are altered in various types of lymphoma and CLL, and many of those pathways can be targeted by medications called targeted agents that will bind to a particular enzyme in the pathway and lead to involution and death of the lymphoma or CLL cells. So that comes with a better therapeutic index, meaning that you get often a very good treatment response without the typical side effects that traditional chemotherapy or radiation therapy provide. And also, many of the subtypes of lymphoma or CLL that were not very responsive to these traditional treatments can respond very, very well to the new agents. So there's a great deal of research going on around the country and around the world much of it sponsored by the Lymphoma Research Foundation, that is helping optimize these new therapies, figure out which patients are most likely to respond and benefit from them, how we might optimize them further by combining, say, two targeted drugs or a targeted drug with an immunotherapeutic agent like rituximab or obinutuzumab, and really get patients into a fairly rapid and a deep remission that will allow them to avoid a lot of traditional toxicities, and ideally, if we are successful with getting a very deep response, then we can have people stop these therapies at some point. And we may have some time to talk about that a bit in the question and answer. So let me go through some background material on adherence, because that's really the focus today. We've got these powerful agents. They can work very well, but they only work if people take them and take them in the prescribed fashion. Because of the mechanisms they work by, it's very important to know the dose and the schedule and to stay with it. And so that's become a focus for Lymphoma Research Foundation efforts. These are my disclosures. So our institution does a great deal of clinical research, some of which is sponsored by the pharmaceutical companies listed here, some by our own in-house research support. I've been a consultant for several companies on their medical development of these agents, and I've had honoraria from Xia and Janssen. As you heard, I serve on the scientific advisory board for the LRF. So back in 2015, the LRF sponsored the first workshop on oral therapies in lymphoma. It was held in Washington, D.C. We identified a number of important topics related to oral treatment of lymphoma, and that led to a follow-up workshop that's listed here. It was held in New York City in October of 2017. I co-chaired this meeting with Dr. Jonathan Friedberg, who's at the University of Rochester, and we had an expert panel for our steering committee, Dr. Christopher Flowers, who has been at Emory University, but most recently left there to join as the MD Anderson Hospital as head of their lymphoma programs. Dr. Neil Kay, a CLL expert at Mayo Clinic Rochester, John Leonard at Cornell in New York City, and Dr. Sonali Smith, who is going to be our incoming chair of our scientific advisory board for the Lymphoma Research Foundation. So the program goals that we had were to understand what are the critical features in managing patients who are on chronic oral therapies. How do we assure that they're being adherent with these medications and not having to interrupt or alter the dosing due to side effects or cost or whatever the reason might be, to figure out what interventions or tools are needed to adequately monitor patients who are on treatment. And again, the context for this just shows the paradigm shift in managing these diseases, because for much of my own career, patients getting treated for lymphoma would be getting, say, chemotherapy every 3 weeks. So they come in to see me, they come to our infusion center, they get their treatment, they go home, we may check blood counts in between, and then they return 3 weeks later. So there are multiple opportunities for me and for our nursing staff and our infusion staff to assess firsthand how's the patient doing, how's the patient responding, are there issues we have to address in adjusting dose or switching to a different regimen. With oral therapies, that's a very different sort of management approach. So I'm not seeing patients as often. We may not be checking interim labs so frequently, and they may be having side effects that if we haven't done a good job educating about these or about what to do, then it may lead to a suboptimal use of the medication. So findings that we had from this workshop related to adherence were that the challenges related to it are very complex and they're hard to quantify because we don't have the same sort of metrics to monitor patients who are on these chronic treatments. That there are existing there are existing methods of adherence assessment and newer technologies, I'll mention some of these, that we can study to learn how best to deploy them to make sure patients are responding and managing their treatment well. So we had some expert presenters at our workshop who informed us about what was known about the management of chronic oral therapies and to allow us to generate hypotheses about what we could do to make sure we're optimally managing these treatments. So Dr. Joseph Greer, who is a psychologist at Massachusetts General Hospital in their cancer center, has a great deal of expertise in oral treatments for cancer. And of course, there are other cancers where oral treatments have been in place for a long time. Classic approach would be, say, hormonal therapy for women with breast cancer, and where they're on these treatments for many years, and they may have both short and longer-term side effects that need to be assessed. So, as I said, and as Dr. Greer emphasizes here, these oral agents have now altered disease outcomes, improving patient survival. It's certainly more convenient in many ways to take an oral drug instead of coming in, getting an IV, or having a port access for treatment. And that in turn improves quality of life by avoiding some of the problems that can come up with intravenous infusions. But, as I mentioned, there's less supervision and often less support for adherence and monitoring. It's also important to recognize that treatment schedules are complex. In some cases, people may be on a single oral drug that they take once a day, which is, pretty straightforward to manage. But when you start to get into combinations of agents where you may take a drug twice a day, every day, there may be another medication that you take once or twice per week, and then maybe on top of that is a dose of another medication that's given less frequently, every 2 to 4 weeks. So being sure that patients understand and they're able to comply with these complex regimens is very important. The more complex it gets, the lower adherence is going to be. And one of the lessons we learned from this workshop and that the LRF has made hematologists and oncologists aware of is that lack of adherence often reflects complexity of a regimen, and it's not because patients are just being careless about how they're taking their medication. I think most lymphoma leukemia patients are highly motivated when they know that, if I take this medication, it's got a very good chance of keeping my disease under control, and so they're going to be pretty vigilant about complying with what needs to be done. So we have to do our part from the physician and nursing standpoint and pharmacy standpoint to educate folks about these regimens. So the National Cancer Institute has, of course, is the major funder for cancer research of all types in the United States, and Dr. Wendy Nelson leads a section at the NCI that has developed research grants to support studies of adherence, and I've listed here in bold some of the topics that are being explored with NCI funding to look at how best to support patients in taking these medications. I'll say a little more in a bit about this issue in the fourth bullet on polypharmacy. So it's very important to recognize that many of these oral agents are metabolized by the liver or cleared by the kidneys in such a way that they may adversely interact with other medications, which could include blood pressure medications or antibiotics. So when you've got someone on, say, an anti-CLL oral drug, you have to be very careful about taking another medication or taking an herbal supplement where we may not know exactly what's in it, or interactions with certain foods that will either shorten or lengthen the half-life of the therapeutic agent. So it can lead to unexpected toxicities or an interference with the benefit of taking the drug. And so that's why we point out to patients who are on these drugs that they should not start another, say, antibiotic if they get an infection 6 months after they've been on a treatment without touching base with the treatment team to be sure that that's safe. This is a cartoon that was created by a patient who has chronic myeloid leukemia, another disease where we have had oral agents that are highly effective to treat these patients. And I've got patients who've been on CML oral agents now for 15 years and more. So as Everett Koop, some of you who are of my vintage will remember him as a former U.S. Surgeon General who said drugs don't work in patients that don't take them. And for many of these very effective agents, like CML, but also CLL and some lymphomas, that very often when suddenly the drug seems to no longer be working, the first thing we need to address is, has the patient altered the dose or the way they're taking it to make sure that we don't give up on a drug that's still capable of working well and switch them to another therapy. So this is one of the several mechanisms that are being developed for monitoring dosing. So this is called a MEMS, or microelectronic monitoring system. So this has a chip in it, and so it's a pill bottle, and when you take the cap off, it records what time that cap came off, and it gives a mechanism by linking through an app or by downloading what's on this chip when you come in to see your oncologist to see how well you've been able to stay in reasonable compliance with the medication. If you see a pattern where the interval of dosing or missed doses are an issue, then it helps us know that we need to address what might be underlying that difficulty. Dr. Smith also points out that there are a number of apps for this where you can communicate with your treatment team. So this is a mock-up of a screen here where you can report in if you're having new symptoms. If you're having something more urgent, you can basically call for help, and you can give feedback. So in real time, you can get patients to deliver information about how they're feeling. Are they having, difficulties with fatigue or nausea or diarrhea or some other side effect, and what's the severity of that? So the care team can thus get information about how somebody is tolerating a treatment and make adjustments or symptom management interventions that can help keep patients successfully on the treatment. You can also set up these apps. Some people find it useful, some people find it annoying, that you get an alarm or a chime that tells you, if you take a drug twice a day, it gives you a reminder about that time has come, so you don't miss doses. But there are concerns about security for such apps. What's the layout? What operating system is? What's the cost of these? Right now, in my experience, many of these are still investigational and being optimized. So a lot of practices don't use them as a routine approach, but they are something that's coming along, and I think we'll see more of them in the years ahead. It's important, as everyone I'm sure on this call knows, that you be your own best advocate. You need to speak up when you've got concerns, and as a provider, a healthcare provider, I have got to make sure that I'm listening so that I can hear cues about what might be going on, and that I'm interrogating patients when I see them about, have they had particular side effects, with, headache, GI symptoms, muscle aches, or fatigue. Those are things that we need to be communicating, and it can be difficult at times. Patients who are perhaps more frail or elderly have a language barrier of some sort, and perhaps we don't always do the best job on our side of being available. So many practices are employing nurse phone-ins to help with this, so that patients have good access for communicating. And just so I don't forget to mention it later, one of the things that has been shown to help patients get off to a good start with an oral therapy is to have either a pharmacist from our team or a nurse coordinator or nurse practitioner call patients several days into treatment to see how they're getting along, if they had any concerns or unexpected symptoms, so that they can be dealt with early, so that we make sure that patients are managing optimally. There's a lot of challenges to capture this sort of toxicity. Again, this is one of the items that was recognized during our conference, and that includes what are the mechanisms of communication, how do we document this. The timing of events when something happens can be unpredictable. And again, a difference of the newer therapies is that many of the oral therapies at this point, when patients start on these, they respond to them and they're tolerating them, they're on treatment indefinitely. So it will be almost certainly months and often years of therapy. So we have to be able to identify not just treatment side effects that may happen in the first days or weeks, but symptoms and side effects that may not become apparent until people have been on treatment for 1 or 2 or 3 years. So capturing these late effects is very important, and again, reminds us that we need to be vigilant with our communication and documentation as we go along. So just to wrap up some points before we get into our questions, we've learned that these oral therapies provide really new models that are needed for caring for patients on chronic therapies. I pointed out the issue of polypharmacy. That can be a real concern, and so if you're on such an agent and you've been on it for 2 years, but then you need another drug added for your hypertension or whatever it might be, you need to vet that change with your treating team. As I said, there are no standardized methods to assess adherence, and no real definition for what, if you're a little delayed with a dose here and there, or you miss a dose here and there, that's probably not so critical, but we need to understand how much adherence is needed to get a good response to treatment. We also recognize that oral therapies are not inexpensive. They can often have high copays, and there are situations where some patients will parse out their medications because of the cost of the drug, and so that's an understandable response, but one we need to be aware of and make sure we're doing everything we can to support that patient to get optimal therapy. And I did mention just now that that some of these side effects, for example, with ibrutinib and other BTK inhibitors, it may not be recognized for a year or two that patients can develop high blood pressure or swelling of the extremities, edema, etc. So that's true for many of the oral therapies, and so we have to be, again, vigilant as we follow these patients over time. So I will turn it back over here to Andrea. I think they may have a few more comments from the LRF before we begin taking questions.
Thank you so much, Dr. Williams. Before we open the program up to questions, I want to share information with you on the Lymphoma Research Foundation that may be helpful to you as you navigate lymphoma and long-term survivorship. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you are utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding non-Hodgkin lymphoma, Hodgkin lymphoma, chronic lymphocytic leukemia, and the transplantation process. We offer a variety of easy-to-understand fact sheets on each of the subtypes of lymphoma, as well as supportive care topics that may be relevant to your lymphoma experience. We also have a dedicated oral therapies fact sheet available and are planning to release a fact sheet on adherence in oral therapies later this year. The Lymphoma Research Foundation also hosts in-person education programs across the country that provide you an opportunity to learn from and ask questions of lymphoma experts who are at the forefront of some of the research that you've heard about today. I would encourage you to visit our website, lymphoma.org, to find out if there is a free educational program in your area. Finally, our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. The app is available for free download in the Apple App Store and in Google Play, and I would encourage you all to download the app today. And last but certainly not least, for those of you who may be looking to give back and help continue to advance lymphoma research, I would encourage you to join Team LRF. We offer a variety of walks and rides for you to participate in, or you could turn your talents and passions into ways to raise funds for lymphoma research. Through Team LRF, you can meet others who have been impacted by this disease and join a community of individuals committed to impacting lives by finding cures for lymphoma. I really hope that you all take advantage of some of the great resources and services the Lymphoma Research Foundation provides. If you have questions regarding what you learned today, or you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. Thank you all again for your time today. We will now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from Dr. Williams' answers. And with that, I will turn the call over to our moderator.
Thank you. If you would like to ask a question, please press star 1. We will take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the Lymphoma Research Foundation's helpline at 1-800-500-9976. Please remember that you can also submit questions via the web. And our first question from the web is there an average point in time in which patients can safely stop taking oral therapies?
So that's an excellent question, and it's one that is the focus of a great deal of research these days. The answer is it depends. It depends on the disease, and it depends on how we can best assess that we've achieved the maximum response to treatment. So most of these oral treatments for lymphoma and CLL are not in themselves curative. So the approach has been that if you have started a drug such as ibrutinib or acalabrutinib for CLL or for certain types of lymphoma, that you stay on that drug indefinitely, meaning potentially for years. Some patients will achieve a complete remission by CT scans or PET scans and their blood counts normalize, that doesn't mean the disease is gone. It means it's just been suppressed to a level that's not detectable by those methods. So to really answer that question, the research that is at the cutting edge right now is to use a technique called minimal residual disease or undetectable residual disease, and that typically involves very sensitive molecular methods to look at the blood or sometimes the bone marrow to see whether you can find any traces of that population of cells, the tumor cells left behind. If you can get patients to MRD negativity, then there is evidence that in some types of CLL and potentially some types of lymphoma, like mantle cell perhaps, or follicular, that you can come off of treatment and monitor for MRD. And if the MRD starts to increase again and become detectable, then you know that's going to foreshadow a relapse, so you can reinstitute therapy. Now, many of the oral therapies by themselves, any single agent, often doesn't get patients to MRD negativity. That's why the interest is right now in combining 2 or even 3 agents to get to MRD negativity, to get that response more quickly, and potentially allow patients to come off of treatment after 6 or 12 or 24 months. So it's an excellent question, and I think certainly a priority for the field to try to get toward limited duration therapy instead of having patients on treatment lifelong. Is there another question?
Thank you. Yep. And the next question is, are there existing chemotherapies in particular that have been developed into oral treatments, and can they be combined with some of the newer treatments?
Yeah, another excellent question. There are a few both older agents and some newer ones that are traditional cytotoxic therapies that can be given orally, such as cyclophosphamide. There are oral forms of fludarabine. There's an agent that's used in acute leukemia and myelodysplasia called azacitidine that has an oral form. And so those are being looked at in combination now with a targeted drug, but it's still very early. They've not become adopted as standard treatment approaches, but there is a great deal of work in combining an oral targeted drug such as venetoclax or acalabrutinib and others with chemotherapy agents like rituximab and bendamustine, or rituximab and the CHOP chemotherapy regimen. So those are being studied. They haven't at this point become standards of care, but there's a lot of interest in, again, using whatever avenues we might need to get patients into that very deep remission to give them the opportunity for potentially cure, or at least a very long duration of disease-free time.
Thank you. And the next question is oral therapy covered by Medicare insurance?
So that's a complicated question and an important one given the expense of these agents. So the answer is yes, but, and this is where there are others who can answer much more insightfully than I can. There's a lot of variation depending on one's insurance plan, the supplement insurance they might have, and especially which prescription plan, which Part D plan that they have. So if you're not on treatment now, or even if you are, when the time comes, each year where you're sort of renewing or reconfiguring your, say, Part D coverage, you want to get some counseling and guidance about which plan is going to be most satisfactory as far as coverage and low copay for these agents. In our cancer center, we have a staff of people that help with these financial questions and with coverage questions. So if you haven't done so already, I think it certainly behooves everyone to seek that kind of information to make sure you're avoiding the financial toxicity that can happen with these agents for a lot of us.
And the next question here is, you mentioned risks that come with drug-to-drug interactions. I have a chronic illness that requires lifelong treatment. Am I still eligible for oral therapy if it's been approved for my lymphoma?
So if it's a treatment that's been approved for your lymphoma, then the answer is yes. Of course, that's something that you have to review with your hematologist-oncologist to make sure that the side effect profile of the drug and for your particular subtype of lymphoma, that all makes sense. It's very valuable to have a PharmD, a pharmacist who specializes in oncology therapies, review your treatment regimen, whatever treatment you're on for, say, another chronic illness, see what drugs and medications you require for that, and to let you know if there are drug-drug interactions. One example that we run into occasionally is we have patients with a chronic lymphoma or CLL who have to be on an antifungal antibiotic. Several of the antifungal drugs have strong interactions with medications like acalabrutinib or venetoclax. And so what we do is decrease the dose of the, say, acalabrutinib, because we know if we gave them full dose, they could end up with toxicities. So you can still take the medication, but your dosing schedule may be different depending on what other medications you're on. And again, the medication interactions can be very important, either in increasing or decreasing the effect of your anti-lymphoma agent. So that's why I have been emphasizing the need to work through that with your hematologist-oncologist or their staff to make sure that you're being as safe as possible and getting the most benefit from the therapy.
And the next question here is, are there oral therapies for first-line treatment in mantle cell lymphoma?
So another great question, and mantle cell is a longtime interest of mine. So right now, there are not. However, there are a number of studies in progress looking at combined targeted drug plus chemotherapy. There are some preliminary studies that have been reported that look very promising of using an oral agent, an immunomodulatory drug called lenalidomide, which is not as typically considered a targeted drug as much as things like the BTK inhibitors or BCL2 inhibitors. But lenalidomide plus rituximab can be a very active agent for frontline mantle cell therapy. It's also been learned from a study that was done here at the University of Virginia and also from a study that was just updated from Australia, that the combination of ibrutinib plus venetoclax is very active in patients with relapsed or chemotherapy-resistant mantle cell. And so with regard to frontline use, a study called the Simpatico study that was sponsored by the pharmaceutical company in relapsed patients has now been expanded to include patients without prior treatment of their mantle cell lymphoma. So in this study, patients get ibrutinib, which is an approved drug for mantle cell lymphoma, and they get either venetoclax or a placebo. So that will answer the question about whether the combination in the relapsed and the frontline setting is beneficial over single-agent ibrutinib. So it'll probably be another, I would think, year and a half or two before we have the frontline data from that study, but I suspect we'll see the data in the relapse refractory patients sooner than that.
And the next question is, are there any toxicities that are standard across oral therapy treatments?
So they aren't standard across all treatments, but there is, to some extent, if you will, a class effect. So, for example, right now in the U.S. we have 3 BTK inhibitors. So BTK is Bruton tyrosine kinase. It's a key molecule in the B-cell receptor signaling pathway, and that's a pathway that's targeted by several of the drugs that are now in use. So if you look at BTK inhibitors, there are some common toxicities across them, such as loose stools or diarrhea, which can usually be readily managed, occasionally rash in the early going, sometimes muscle aches and pains. There's a variable risk of things like atrial fibrillation and bleeding, which are infrequent, and they differ in frequency across the agents. So that's an example of commonalities that you might see. Another class of drugs are the PI3 kinase inhibitors, which have activity in a variety of lymphomas. There are several of these drugs as well that can be quite active, but they can have toxicities where they can have late serious toxicities that can include inflammatory bowel disease like colitis or inflammation in the lungs, a pneumonitis. So that's a sort of a class effect, although the severity and the frequency differ across individual agents. So so those are things that we take into account when we're prescribing an agent for an individual patient. And of course, we make great efforts to educate patients about some of these side effects so that they can be on the lookout and notify us at the earliest sign that one of these toxicities might be occurring.
Thank you. And the next question here is, how does a patient prepare to receive a lifelong oral therapy? What does follow-up care look like long-term?
Yeah, so a great question. And so there's no standard for what managing it long-term looks like. I think patients are typically monitored pretty closely in the first weeks and months of therapy, but once we've seen that they've had a great response, their CLL is in remission, or their mantle cell lymphoma is under good control, they're tolerating the drug, then they may only be seen in their oncologist's office every 2 or 3 or 4 months. So this is where the sort of monitoring of potential toxicities and to be sure patients are maintaining their adherence can get a little harder to track. So we're learning about how to improve that management. We've also learned, like I said, with things like the BTK inhibitors, that we've learned that after people have been on the drugs for a year or 2, they may develop some side effects like elevated blood pressure or sometimes swelling in the legs. And so as people are on it, we start reminding them about, we're looking for this when we see them, but we remind them to let us know if they start observing some of these toxicities.
And the next question here is, sometimes I miss 2 to 4 doses per month simply because I forget to take them. Could this significantly affect my remission?
So if it's you're missing a dose every week or 2, it's very unlikely that that's going to have an impact on the ongoing remission. If you're missing 2 or 3 days in a row, then that can have some impact as well. So Ideally, there are no doses missed, but that gets harder in my experience, even with people who are on patients that are on a twice-a-day drug as opposed to a once-a-day. That over time you get busy, you're out somewhere, you forget to take your medicine with you, and you miss it. That's usually not a big deal. But if you're chronically missing medications, then you could start to lose the impact. So the way these drugs work is they often just suppress the growth and proliferation of these cells, but they don't eliminate it. So if continued response requires that the drug is binding to that target in the cell, and you get decreased targeting of that molecule, then the cells can start to escape and regrow if the dose intensity has decreased. So 2 to 4 doses a month, not likely to have a major impact on therapy, but consecutive doses missed, taking a drug holiday for some reason, maybe patient's been having some side effect or they ran out of the medication and the shipment didn't come, those are things we try to watch and prevent.
And the next question here is, if the disease is suppressed to normal levels, is it reasonable to discuss with your doctor lower doses in order to minimize toxicity and side effects on oral treatments?
Yeah, great question. Not a lot known about that at this point. It sort of following on the answer to the last question, it's necessary a lot of times to keep the target activity suppressed so that the disease doesn't start to escape and re-expand. So there's not a lot known about being able to use a lower maintenance dose of a lot of the targeted drugs, like the BTK inhibitors or venetoclax. Immunomodulatory drugs like lenalidomide, you can often decrease in the dose in the maintenance phase. So right now, it's generally not recommended that a dosage be dropped even though you've had a good response. We try to keep you on that dose to maintain that ongoing response.
And the next question here is, please give an example of comorbid medications that may interact with CLL treatments.
Right. So there are certain antibiotics is a common one. As I mentioned, some of the antifungal agents. There can be interactions with other antibiotics with certain of these agents, such as Cipro or Levaquin and others. So those need to be checked depending on which agent and regimen that you're on. There are certain foods that can interfere. For example, many people are aware of the fact that grapefruit juice and Seville oranges can interfere with metabolism of some of these drugs. So those are the sorts of things that you have to be cautious about. It's a very common question that we get from patients about, well, should I be taking a supplement of some sort? And, whether it's an organic compound or an herbal supplement, the difficulty with that is that, those are not FDA-regulated products, and so the manufacturing is not as regulated. Any adulterants or other things that might be in there are often unknown, and they may vary from batch to batch of the treatment. And there can be substances in herbal remedies that, again, might interfere or interact with treatment. So I recommend that patients avoid taking those substances where we can't be confident about the risk of an interaction that might, again, cause a toxicity or cause a decrease in response.
And And the next question is, what is the best oral drug currently for CLL?
So it's not possible at this time to say what is the best drug. CLL, as with each of the individual subtypes of lymphoma, follicular, diffuse large B-cell lymphoma, mantle cell lymphoma, although they look the same under the microscope, more or less, and they have a lot of the same characteristics in testing, we know that at a molecular level they're quite variable. So CLL has a spectrum from a very slow-paced disease that may not require treatment for 10 or 12 or 15 years. Other subtypes of CLL, those with a deletion in the 11q chromosome or in 17p, the p53 mutation, those tend to characterize CLL that's going to have a more rapid progression. So for patients with 11q or 17p, then the upfront treatment for those is going to pretty much always be a BTK inhibitor or the BCL2 inhibitor venetoclax, either alone or in some combination with a monoclonal antibody. Whereas for lower risk patients, they may be able to do very well with a single agent of, say, ibrutinib or acalabrutinib. There are studies ongoing now, some that have just been reported in the last few months in the literature or at the American Society of Hematology meeting, looking at patients younger than 65 and older than 65, comparing frontline treatment with a targeted drug, with or without an antibody like rituximab or obinutuzumab, with standard chemotherapy regimens. And those have pretty uniformly shown a marked improvement for using a targeted drug. So whether ibrutinib or acalabrutinib differ in terms of their efficacy, is probably, I think they're probably quite similar in activity. They have a little different toxicity profile. So it's those sorts of things that weigh in. I think the important take-home is that we've got an array of these targeted drugs now, and that we try to adapt the drug and the dose to individual patients depending on things like their other medications, whether they have a degree of kidney insufficiency or liver disease. So those are all things that have to be taken into account. So there's still a lot of art to the science of treating lymphoma and CLL. So it's I wish it were as simple as one drug that's the best for everyone, but that's not the nature of the disease or the biology of it.
And the last question is, if I failed 2 oral treatments, what are my next options?
So this obviously depends on what disease is being treated and which 2 treatments have failed to provide benefit. There are a lot of clinical trials going on that are looking at ways to approach people who have patients who have relapsed. Sometimes you can add a second drug. Let's say if you failed ibrutinib or you were intolerant to it and you switched to acalabrutinib and then became unresponsive to that, sometimes you can continue the acalabrutinib and add venetoclax to it. So usually what we'll do is if you fail, say, a BTK inhibitor, is to switch to a different class of drug, like the BCL2 inhibitor venetoclax, or perhaps one of the PI3 kinase inhibitors, or lenalidomide, with or without an antibody. So there are still options, but it gives me a chance to say that whether it's initial treatment or a relapse situation, for many of these diseases, a clinical trial that's looking at what is, say, comparing the very best current treatment options with what we think is going to be better based upon the science of an understanding of individual subtypes of lymphoma or CLL. And the Lymphoma Research Foundation, I'll just perhaps close by saying that the Scientific Advisory Board meets and reviews high-quality grants from around the country to fund the very best science that is looking at exactly these types of questions. And it's helping accelerate progress in the field, which, as I said at the outset, has been just nothing short of dynamic. It's exciting to see patients who not too many years ago would have had no really meaningfully effective treatment options, and now they can achieve excellent disease control and become symptom-free with the benefit of these new treatment approaches.
Thank you again to each of you for joining us on today's call, and we hope that you found the information both informative and also hopeful. Please remember, if you have any additional questions or would like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as they are important for helping LRF to ensure they deliver the most useful and meaningful programming to you. And with that, I would like to thank you all again for joining us, and have a wonderful day. Goodbye.